So I started at Virta about a year ago, and before that I worked at North Shore in a health system where we did deal with some of the struggles of interoperability, see that firsthand. But one of the cool things that we did there was use machine learning and data science to really improve the care for patients. And I'm going to be talking a little bit about that and how we've been able to do that at Virta. I've also done some fun stuff with NFL predictions and music, and so if anybody wants to talk about that, happy to chat about that afterwards as well. So what I'm really interested in is how we can use machine learning to drive action and allow clinicians to do their jobs better. So there's many aspects to machine learning in healthcare, a variety of topics we'll be discussing today, but that's what I really want to focus on. I think there's two major parts to that. One is working with clinicians from the very start, at the beginning of your machine learning data capture process, all the way through to the end, iterating with them, communicating those results to them. And then the second piece is, as you're developing models as a data scientist, thinking about interpretability and communication. And sometimes you might want to sacrifice the accuracy of a given machine learning model to do so. And that can have a greater impact sometimes. So I'm going to discuss one case today. But before I do that, let me tell you a little bit more about Virta. We had a little bit of intro from Hatch and Sami. There's 5 major components to our online clinic for type 2 diabetes reversal. We have biomarker tracking in our app, measure stuff, weight, and blood glucose, ketones, track all that information. And then there's educational material. There's a community support, other people who have diabetes can discuss issues that are going on. And then you have a physician and a health coach who are overseeing your care. And the health coach provides daily support primarily through text messaging, also sometimes phone calls. And here's a look at the patient journey. You're not supposed to be able to read it. It's supposed to look complicated and cool and fun colors. And the idea is that all these different colors represent stages that patients are going through. And they might hop around, although it's laid out sequentially. They get different badges, and the little gray blotches there are videos and educational material. And the idea is that for every patient, providing the right care to get them to reverse their diabetes can be complicated. There's different routes to take. And what I'm really going to focus on today is the early part of that journey, the first 14 days. And what we're interested in is what data can we capture during that time to see if people are going to stay with us at Virta. Are they going to remain in the clinic, or are they at risk of dropping out? And this is the idea of how can we use machine learning to predict who's likely to drop out and then provide that information to clinicians so that they can help intervene, get people back on track, and have them succeed. So at the very beginning, the patients are given some preparation and core concept material. A big part of what we do at Virta is instruct people on how to restrict carbohydrates and have a low carbohydrate diet. And then they undergo dietary changes around day 5 or 6 or 7. And after that, we're continuing to work with them and collect information. So collect biomarkers, and those text messages are going back and forth. So here's a look at how we did with regard to retention, as I mentioned, talking about people dropping out of the clinic. So this is a sample of data. I'm going to show some more charts, less videos in this talk. The idea is here is that at the end of 1 year, we had 82% retention in our clinical trial cohort, which is pretty good for this type of intervention. But can we do even better? What can we do? Can we identify those people early on and provide them care and assistance and interventions to get them back on track? So 90 days, it was 94% retention, so 6% dropout. That's a number that we'll revisit. So when it comes to action and decision making and using machine learning to assist clinicians in that aspect, I think it's really important to frame the problem in a certain way. So it's not only about who's likely to drop out, but can we get insight as to why? So the who is a common machine learning classification problem. And you can rank people from high to low, who's most likely to do a certain thing. And I want to try to think about, can we understand the why, at least a little bit, as a first pass? What are the things we can do to accomplish that goal? Importantly, working closely with clinicians who are using the model. This isn't something that's directly patient-facing. And the two requirements that I mentioned at the beginning that want to make sure that the results are easy to communicate, so clinicians can incorporate that into their workflow, and that they have some transparency into the model. How does it work, and what's useful? And so that should help with a prioritization of which of my many patients do I take care of, where do I focus my time and energy, and then also for a given individual, what to focus on. This is one of my favorite quotes. All models are wrong, and some are useful. And so how do we build useful models, right? Models by design don't capture everything. They're an abstraction, and the idea is to build some simplification. Sometimes you can do that, but you kind of lose track on what's actually useful. So that's a theme I want to come back to. All right, so we're going to delve into the modeling here. We're tracking a lot of data through text messages. You can look at things like how long is the average message? How frequently are the messages being sent? And then use some other machine learning algorithms to figure out what they're talking about. And is it an urgent message? So Jackie will be talking about some of those topics a little bit later. And then the biomarker tracking, weight, glucose, things like that. So we can incorporate all that information, and started with looking at over 100 different characteristics, right? So all these things based on clinical intuition and research in the field of what keeps people staying on a program like Virta. And then narrow that down using feature selection, right? So over 100 variables, maybe you can develop a very good model, but it's a little bit cumbersome and hard to understand. So using random forest out of bag error, you don't know what that means, we can talk about it afterwards. And then in combination with a simpler, straightforward logistic regression that's easy to communicate with physicians. And narrow that down to 15 of the top characteristics out of that 100. So I'll just talk about a few. And a nice advantage of logistic regression is you can get some directionality and understand if something's positively or negatively correlated. So for example, what we found is, during those first 14 days, if people are texting a lot about their discomforts or they're reporting a lot of fatigue, they're more likely to drop out. And on the other hand, if they're a little bit older or if they're experiencing more weight loss, they're more likely to stay in the program and stick with Virta. You see that? Looks good on there. Yeah. So this looks like Instagram. That looks like that. It's got a long tail, and the average is around 15% or so. So this is what the model actually produces in our historical data. It's a skewed distribution, and there's fewer people at high risk and a lot of people at low risk. This one's a little bit easier to read. So how did the model actually perform? So we use over 100 characteristics. This is a machine learning model. Well, we can look at our historical data that we use to develop the model and then actually see, are the predictions lining up with what actually happened? Pretend like we don't know what happened, see does it line up. So if we break up those risk probabilities into different levels, so low, medium, and high. So for example, low would be the people who were between 0 and 10% at risk of dropping out. What actually happened? Well, it's right around 5 or 6, as you might imagine. And then let's take a look at another point. So people between 25 and 45% risk, well, right around 35% actually dropped out. So this gives us some confidence in the model that we're actually detecting things that are related to dropout and make some accurate prediction. And in addition to that, again, bringing the clinicians who we're working with throughout the entire model development process, I went and ran the model and asked them about, hey, you have this patient, rank ordered list who are at high risk. Does that agree with your intuition? For the most part, it did. There are a few surprises on that list, but that was some good confirmation. So now that developed this machine learning model, the instinct as someone who's working on that model and understands probabilities to deliver this type of report to the health coach, who I can say, you have 3 patients the rank order from highest risk to lowest risk. So spend more time on patient 1. And the health coach come back to me and say, well, okay, they're at risk of dropping out, so why? What do I do about it? And so a better way to communicate that information is to think about those different aspects that went into the machine learning model. And instead of necessarily reporting a number like 31.9, just report the level of the risk. It's high risk, just kind of splitting hairs between 30.4 and 31.9. And look at different aspects of those different factors that contribute. So for example, this patient had relatively high reports of fatigue, whereas this one was texting more about discomfort. This one had relatively low weight loss. And as a clinician, you focus on different aspects for a given patient, provide that personalized care. All right, so what actually happened? So we deployed this model about 3 months ago. So that's what I was saying, let's keep that 3-month number in mind. And right now, the retention is up around 98% at 90 days. And so we're projected to get out to 94% if everything keeps cruising as it's been going so far. So that's exciting, that's interesting. And from talking to coaches, what do they find that's useful? Well, it is helpful for prioritization. Who needs a little additional care? It's also good for focusing efforts on different aspects. Maybe one person's weight loss, another person it's fatigue or dehydration, something like that. But I can't take all the credit, right? So there's a lot of other stuff going on. It's a different patient population. Of course, our products and services have been getting better since that initial cohort. So I just want to summarize in a few key points. When we're building machine learning models in healthcare to drive clinical decision making, I think it's really critical to think about how to make that interpretable and easily communicated to whoever's the end user, in this case, our health coaches primarily. And then collaborating with them throughout the process, thinking about what are the challenges that they're facing. Is this making sense? Does it agree with your intuition? And what's working, what's not working, iterating. And sort of tying this together, if we think about high frequency, so high frequency in the healthcare context isn't that fast compared to some other fields, but having information every day as compared to working in a hospital system where we would get information maybe every few months or a year, combined with machine learning and a high-touch model creates this nice feedback loop where we can get information, get it back in the hands of clinicians, and allow them to provide it. And lastly, why we're really here. So I showed some charts and tables, but it's really about, can we help more people? Can we find out what's going on with them, provide that personalized touch? And so, quick story is one of Catherine's patients, Catherine's a health coach, showed up on the list as having a high risk of dropout. And one of the indicators was low weight loss, but wasn't reporting too much fatigue or other discomfort or anything like that. And so when Catherine dug into it a little bit, she figured out that, well, this person had some other issues going on and was taking medications that actually limited weight loss, and persuaded the patient to focus more on the improvements in glucose and blood sugar. And that reframing, long story short, really helped that patient get back on track, and is now 4 months in and a lot more successful than when she was in those first 14 days. All right, so thanks. We have a great cross-functional team working at Virta. I'm working with the health coaches pretty closely, research team, and operations. Jackie's going to tell you a little bit more about some other data science fun that's happening at Virta. Thanks.